that was initially essentially hospital bed pressures, had a lot of observations in the day, and then when patients stayed in the hospital, we had quite a few delayed discharges. And we also wanted to see if we can improve patient experience through day surgery path. So I'm going to give a little background and then describe the pathway. So this is not a new concept. It's been around for a number of years, and it's been shown to be safe in a few centers around the world, low admission rates. But in the UK, there's been a few strong cases, and until recently, we've not an established pathway. But we do have a lot of experience in the UK with anti-arrhythmic surgery. It's on the goals to expand day surgery for hydrogen repair. And we know it's safe, but there's a lot of variability in practice. So we know that this surgery on post-operative day one is safe. We've been doing this now for more than a decade. And more generally, bariatric surgery is safe, and as safe as other common day surgery procedures, with low mortality like cholecystectomy, and make the patient serious. And when you look at day surgery in bariatrics, in the previous decade, in the previous decade, there were a few centers that were doing it with very good results, and we see that unplanned admission rates were down to 1.8% when there were discharge facilities for the patients, so not necessarily the patient's home, but hotel facilities. And then more recently, this is the largest study with 30,000 patients with variable success rates, but again, quite safe in terms of outcomes. So why do patients stay in the hospital? Well, there's three issues, mainly nausea and vomiting, pain, and then anxiety from both the surgeon and the patient in terms of using day surgery. But when we ask patients would they want to have a day surgery pathway, we see that almost half of the patients would say yes, and then from these patients, a majority would go on to have their procedure on an outpatient basis. There's high patient satisfaction when we do go through day surgery pathways, in quite a few patients serious. And we saw in the US at least that the numbers are increasing in the last 5 years, particularly when we're talking about sleep hysterectomy, not so much about gastric bypass. But with the increasing numbers, we've seen issues about patient safety. So already from 2018, there was a study showing higher morbidity and readmission rates, as well as reoperation rates. And then 6 months ago, quite a large study, retrospective, but showed double the mortality for the day surgery in the US compared to admission. So these are things you have to think about when you implement those pathways. And a number of centers are using remote monitoring as a way to ensure patient safety. And remote monitoring with wireless wearable devices is interesting, is innovative, but there are issues with implementation. A lot of times it doesn't work. Other times you get a lot of false positives and alarm fatigue. But as more centers are implementing it, we see it working more and more. So we use this remote monitoring device. It's wearable. It gives us saturation, ECG, non-invasive blood pressure measurements, and so there's a mobile phone app that can give us notifications. And the good thing with this device that's different from other devices is that it can be customize the alerts to every individual patient. So when we introduced our pathway, we wanted to prioritize patient safety. So we chose hotel facilities close to UCLH initially to discharge the patients. We kept the patients for 6 hours, which is more than we do for our other day surgery patients. And we used the remote monitoring device I just spoke to you about. And then we did post of day one blood tests and reviewed the patients to ensure they were okay. We had a look at the literature, but we had a look at our own outcomes. Our length of stay before the pathway was introduced was 1.6 days for sleep hysterectomy and gastric bypass. And then we looked at medications post-op, and we saw that our patients don't need a lot of medications, particularly for pain relief, which is quite common for bariatric surgery. We went through clinical governance, the patient safety committees, and then we built a team. And what's important here is that you get buy-in from your recovery and day surgery staff. And UCLH, we are lucky to have a UCLH at home team. This is a team that will go and do blood tests in the patient's homes, and they will monitor the monitoring device for us. And then we tested the equipment in inpatients, and we saw that there was agreement between the ward observations and the remote monitoring device. We got patient feedback, which was quite important. So 2 things from the first few cases. Patients were very happy, but also they gave us a lot of tips on how to improve the pathway. So inclusion criteria, these are fairly common across all pathways. We chose BMI 55 as a cutoff, and we tried to do operations that could be completed within 2 hours of operative time. And then exclusion criteria, OSA on CPAP, which I will talk about later, and we also exclude some patients with chronic pain and opioids, although we are looking at that again to see if we actually need to do that. And so the pathway starts from the education session. We tell the patients this pathway exists. We try to let them know in the one-stop clinic, and then we recruit them in the face-to-face surgical appointment. During the MDT meeting, our anesthetist looks at the notes, we discuss suitability, and then after the assessment we confirm suitability, and we might stop the pathway at any time. Then they are admitted first on the list at 7:30. We stipulated that the consultant surgeon must be present in theatre for these cases, but our fellows usually do the procedures. Operative time less than 2 hours, and we keep them in for 6 hours in recovery day surgery. Management of nausea and pain, we're trying to standardize this to make sure that we have a standardized protocol, which is not very easy across different anesthetists. And we try to do the things we always do to minimize pain, laparoscopic suturing for sleep respecting extraction sites, not using retractors, not using drains. This is our anesthetic protocol. This is one of the biggest problems, trying to get all the anesthetists to use similar methods. But our anesthetic lead has managed to find a consensus, which is very important. And then on day surgery, the most important part of the pathway is our CMSs. So if you have a specialist nurse trying to get the patients home, you usually will go home. And then getting the day surgery team to understand that this is safe after years of not having this experience is very, very important. We discharge the patients to a virtual ward for our UCLH at home service. The surgeon gives them a phone call at 10 in the evening. We have a bariatric on call with UCLH, it's part of our on call, and they are on continuous monitoring overnight. We have a checklist for discharge before they leave the hospital, and then we also did a traffic light card for the patients so they know where to come back to the hospital and ask for help. And then on day 1, bloods at 8 in the morning, and then when the bloods are back at 11, we get a telephone call, but we also run a clinic on the same day. So if the patients want to come back and see us at the clinic, it's their choice, they can come and do that. After that, the pathway manages with our normal patient pathway, so it's a routine care. So we started running in early 2022, we started slowly, and we're now doing more and more cases. We've done 36 patients so far by 3 surgeons. A mix of bypass and sleeve, not so many room-wise, and more than 50% of the procedures were performed by trainees, which I think is important. Doesn't mean that you have to do this procedure yourself, but we do stay in theatre for these procedures, at least in the initial period. And we had 2 failed discharges, both sleeve gastrectomies, and it's interesting that while the numbers in the literature are almost 90% sleeve gastrectomies, these are the patients that are a little bit harder to discharge in terms of nausea and vomiting. The one anastomosis gastric bypass we find are ready to go a few hours after surgery. No patients were recalled to hospital. You will see if you do this very low oxygen saturations. The problem here is that on the wards, if patients have low SATs, they will receive oxygen as part of the MUSE, so then you won't see the SATs. So how you use MUSE in outpatients is different. You need to have different thresholds. A lot of these patients obviously have low SATs at home, so we need to get used to these numbers. Initially, you have the whole team looking at the monitor, trying to make a decision overnight. And then, in some cases, there's missing data. So sometimes the devices get disconnected, and we realize that educating the patients before is very important. Yeah, just getting there. So with very good patient feedback, and what's good now is that our pathway is very popular with our patient support groups. So in conclusion, we present our experience in an NHS hospital in the bariatric day surgery pathway. We've shown it reduces cancellation, reduces cost, it's safe and increases patient satisfaction. We can do it with a hospital at home approach. And our non-clinical managers and our MDT are now very keen to continue this. We're aiming to do 50 cases next year. We'll try to reduce costs further. Do we really need blood tests on post-op day 1? Maybe not. We try to do 2 cases per list, finish before 12. There is already evidence that OSA patients with CPAP can be managed in this pathway, and we will further develop the hospital at home approach. And obviously this is a team approach. There's many members of the team that work together for every patient, and not only the bariatric team, but our critical care research team, which is providing the remote monitoring our day surgery and UCLH at home team. So I want to thank them all for this, and thank you very much.